Hello, my name is Raichel Bello, and I'm a pediatric endocrinologist at Schneider Children's Medical Center of Israel. I want to thank the organizing committee for the invitation to speak today about bone health in children and adolescents with DMD. I have nothing to disclose. Multidisciplinary approach is essential for optimal management of different aspects of DMD. Patients with DMD are at high risk of various endocrine and bone health complications resulting from the high glucocorticoid doses used. In my talk, I will focus on bone health. Muscle strength is a major determinant of bone mass accrual during growth and development in normal children. Daily mechanical stress stimuli, like walking and climbing stairs, are necessary for physiological bone remodeling. Progressive muscle weakness in DMD can significantly hamper bone mass acquisition. Glucocorticoid treatment preserves muscle function in DMD, thus allowing a longer stimulus of muscular activity on bone accrual. The sooner they are given, the greater the possibilities to slow the disease. On the other hand, glucocorticoids influence the regulation of different hormonal axes like growth hormone, sex hormones, and vitamin D that directly or indirectly affect calcium and bone metabolism and have a direct effect on bone cells that may lead to bone mass loss. What do we know about the rate of fractures in boys with DMD? The UK North Star database published data on more than 800 boys with DMD from 23 centers. 80% of the boys had fractures. A third of them were vertebral and 2/3 non-vertebral. The incidence of fractures increased with age, and by the age of 11, 50% of the boys had their first fracture. The overall incidence of fracture was almost 2 times higher than in healthy boys, and the overall incidence of vertebral fractures was more than 500 times higher than in growing boys. The true vertebral fracture prevalence may be even higher because vertebral fractures are frequently asymptomatic. In multivariate analysis, hazard ratio for sustaining the first fracture was increased by 16-fold in those receiving daily deflazacort, and by 3.7-fold in ambulant participants. The increased risk of vertebral fractures led to the recommendation of performing lateral spine radiograph at baseline and follow-up every 1 to 2 years. What tools do we have to measure bone density and turnover? Dual X-ray absorptiometry is the most widely used densitometric technique. However, bone mineral content and bone mineral density are difficult to interpret in children and adolescents. Current recommendation uses total body less head BMD and lumbar spine BMD as the preferred sites of measurements. DEXA provides an aerial BMD derived from the ratio of the total amount of bone mineral content to the projected area of bone, gram per square centimeter. Aerial BMD is not a volumetric density due to the inability of DEXA to measure bone depth. Bones grow non-uniformly in 3 dimensions during childhood and adolescence. The impossibility to account for the 3rd dimension leads to falsely low results in small patients with small bones and falsely elevated results in tall subjects with larger bones. To avoid false BMD scores, compare to reference data for the same gender and age by calculating a Z-score, not a T-score. Various adjustments for bone shape and size have been proposed: height, age, skeletal maturation, pubertal stage, etc. But there is no consensus on what the best way to do it. The International Society for Clinical Densitometry published their position statement on the diagnosis of osteoporosis in children and adolescents. 1 or more vertebral compression fractures is indicative of osteoporosis in the absence of local disease or high-energy trauma, or the presence of both a BMD Z-score below -2 SDS and a clinically significant fracture history, which is one of the following: either 2 or more long bone fractures by the age of 10 years, or 3 or more long bone fractures up to the age 19 years. Remember that vertebral fractures can occur in children who have BMD Z-scores higher than -2 SDS. BMD Z-scores remain useful to determine the overall trajectory of bone health in an individual child and thereby guide frequency of lateral spine radiographs during the monitoring phase. Markers of resorption represent the gradation of type 1 collagen and include N and C terminal telopeptides, NTX and CTX, hydroxyproline, collagen crosslinks, and acid phosphatase. Markers of bone formation include osteocalcin, bone-specific alkaline phosphatase, procollagen, N and C terminal propeptides formed during type 1 collagen synthesis. What evidence do we have about bone density and bone turnover in DMD? In 2003, Binacci and colleagues looked at 32 ambulatory boys with DMD. 10 had never taken corticosteroids. 22 boys were on long-term prednisone therapy at a dosage of 0.75 mg per kilogram per day for a mean duration of 3.2 years. The two groups of patients were comparable for age and oxalogical variables. A significant positive correlation was observed between lower limb BMD and muscle strength. In both groups, BMD was lower than normal, both at spine and on total body, as indicated by the negative Z-scores. BMD at spine was lower in corticosteroid-treated than in untreated children. However, after adjustments for body surface or vertebral volume, there was no significant difference in the spine Z-scores. In corticosteroid-treated children, a negative correlation was found between the cumulative corticosteroid dose and the spine BMD Z-score. What about bone markers? In both groups, NTX, the marker of bone resorption, was approximately 3 times the normal value, and osteocalcin, the marker of bone formation, was at the upper limit of normal. Vitamin D levels were low and significantly lower in the corticosteroid-treated children. To answer our questions, we now have evidence that corticosteroids reduce bone density, especially of trabecular bone, increase bone resorption, and decrease vitamin D levels. So what can we recommend for treatment? This study prospectively followed 33 patients for 3 years, 1 year of observation and 2 years of treatment with vitamin D and adjustment of dietary calcium intake of at least 1 gram per day. All boys were treated with prednisone 1.25 mg per kilogram every 2 days. Dietary calcium increased during the intervention period of the study. At baseline, serum vitamin D was lower than 50 nanomole per liter in 60% of the boys. With vitamin D treatment, serum D levels normalized in all. In accordance with the rise in vitamin D levels, PTH levels decreased. Urinary calcium was lower than normal at baseline and during the year of observation. Later, normalized during the intervention period. At baseline and after 1 year of observation, CTX and NTX, markers of bone resorption, were much higher than normal and decreased significantly during intervention period. How did BMD change during the study? Both spine and total body less head Z-scores significantly improved with therapy. Changes in spine and total body less head BMC correlated positively with changes in vitamin D levels and negatively with changes in anti-X excretion. What about fractures? At baseline, 20% of the patients had long bone fractures. During the observation and the treatment period, rate of fractures decreased, however, not significantly. No vertebral fractures were found during the study. Treatment with vitamin D and adequate calcium intake were able to increase BMC and BMD, especially at lumbar spine, and decrease bone resorption. Serum vitamin D levels should be checked and supplementation should be prescribed with a target level of at least 30 nanogram per ml or 75 nanomol per liter. Note that there is a controversy regarding optimal vitamin D levels, and other published guidelines recommend vitamin D target of 20 nanogram per milliliter or 50 nanomol per liter. The usual doses that we use is about 2,000 international units per day. However, often, glucocorticoid-treated children need higher doses to reach the target. If calcium intake is less than the recommended intake for age, appropriate dietary intake should be provided according to the Institute of Medicine guidelines. Let's move to bisphosphonates. These are pyrophosphate-derived medications that inhibit osteoclastic function. Nitrogen-containing bisphosphonates act through disruption of the mevalonate pathway involved in osteoclastogenesis. Reduced bone resorption and ongoing bone growth and modeling results in increase in bone mass and strength. Only small retrospective studies were published to date regarding the efficacy and safety of bisphosphonate treatment in DMD. Altogether included 116 patients. Results of both oral and IV bisphosphonates in varying doses were reported. Primary endpoints were either pain control or BMD improvement. Although limited in number and design, studies have shown maintenance or improvement in BMD, improved vertebral body shape, and reduced pain. Gordon retrospectively calculated survival rate of 42 DMD patients on steroid therapy. 16 patients, 36% of the group, were treated with oral or IV bisphosphonates for median durations of 6 years. Treatment with bisphosphonates increased longevity, especially if treated more than 6.5 years. This study provides further rationale for active treatment of osteoporosis. A recent Cochrane review concluded that there were no high-quality randomized controlled trials evidence to guide management of osteoporotic fractures in DMD. However, therapy is recommended in the presence of fractures, particularly vertebral fractures. Mild and asymptomatic vertebral fractures are predictive of future fractures, requires monitoring for deterioration. Treatment of asymptomatic, moderate, and severe vertebral fractures and multiple long bone fractures is now recommended. IV bisphosphonate had a protective effect on spine BMD and vertebral morphology in controlled trials of osteogenesis imperfecta and in uncontrolled studies of OI and DMD. Different protocols for IV bisphosphonate is suggested by different institutes. Usually, zoledronic acid is given in lower doses and less frequent than pamidronate. We must not forget potential side effects of the treatment and discuss them with our patient and family. What does the future hold with respect to treatment? Denosumab is a human monoclonal antibody that halts osteoclast formation and reduces the activity and longevity of existing osteoclasts. This anti-resorptive agent targets rank ligand to prevent the activation of rank, thereby inhibiting bone resorption. A 13-year-old boy with DMD and glucocorticoid-induced osteoporosis was treated with denosumab for 18 months. Treatment resulted in increased lumbar spine BMD at 12 months, reduced bone resorption markers without complications. Denosumab's effect is much shorter than bisphosphonates, with scission resulting in rebound of bone turnover markers, as you can see on the left panel, declines in BMD, and even increases in vertebral fractures in women with postmenopausal osteoporosis. These observations appear to result from reactivation of osteoclasts in the face of denosumab's waning effect. Teriparatide is a recombinant human PTH analog. This anabolic agent has a black box warning against its use in children because of osteosarcoma in growing rats treated with doses 3 to 50 times higher than the adult human equivalent and for much longer duration. A recent case report of teriparatide in a 20-year-old male with DMD described complete resolution of vertebral fracture-induced back pain following 6 months of therapy, along with increases in lumbar spine BMD, in bone biomarkers, and improved quality of life. Some take-home messages. At each visit, take a fracture history, assess bone and back pain, discuss strategies to prevent falls. Calcium intake should be assessed at least annually with recommendations to achieve the Institute of Medicine age-related intake through diet or supplementation if daily intake is inadequate. Check vitamin D levels annually. The lowest acceptable vitamin D levels is 20 nanogram per milliliter, which is 50 nanomole per liter, with the ideal target being above 30 nanogram per milliliter, which is 75 nanomole per liter. Diagnose and treat the earliest signs of fractures, including vertebral fractures. Conduct lateral thoracolumbar spine radiographs before and during corticosteroid treatment every 2 years or sooner if back pain or more than 0.5 decline in spine BMD Z-score on serial BMD measurements. DEXA is recommended annually in all patients. Bone size should be adjusted by using height-corrected BMD Z-score or other techniques. Treat osteoporosis according to ISCAD guidelines with IV bisphosphonates. Goals of therapy are absence of long bone fractures, stable healed vertebral fractures, absence of new vertebral fractures, absence of bone and back pain, and height-adjusted BMD Z-score above -2. And with that, I conclude. Thank you very much for listening, and I wish you all a happy and healthy new year.